this would be more interesting. So let's welcome everybody on this platform. As we know, we are a medical coaching and data flow company dealing with all PROMETRIC exams. We provide quickly the 1000 MCQ book, right? Hard copy book and e-copy book. We have online subscriptions, online coaching, live coaching by the experts. This lectures taken lively by the experts in their own field, like gynecologists, pediatricians, surgical people. We also provide Oman Viva coaching and subscriptions, data flow services, some short package for second or third attempt people. And we have a mobile applications too. So those who did not so far downloaded the mobile application on Android as well as on iPhone, I request excellent web this applications we made it, and you can completely surf all the website through the mobile application. This is myself, Dr. Munjal. I by profession I'm a hematologist and oncologist. Almost more than 20 plus years of clinical experience with 10 years plus coaching experience. This is Dr. Arti, who is a consultant pediatrician and she is taking regular lectures for pediatrics and neonatology. Dr. Maddie is again a emergency physician and internal medicine doctor. She is based at Oman, Muscat. She is our regular coach. Dr. Sikha, she is a consultant gynecologist, also taking regular lectures on gynec, and this gastroenterologist, Dr. Ankit Patel, and a few other teams as well. Dr. Anjali is also with us. Dr. Meghna is also with us. So they are taking care of data flow. This is our hard copy book recently updated in January 2024. So it's a compilation of 1000 plus latest MCQ with answers and with explanation. And this is last but not the least. There are a lot of requests from the doctors that coaching is a bit costly. Just to cope up with that, we make it almost half the way, right? Earlier, the 40 hours of coaching used to be 500 USD. Now it's make all universally everybody to 250 USD. So now it's very easy access for the coaching as well, especially those who are a bit new, doesn't have the concept, or they wants to strengthen the knowledge. They can definitely join, and it is absolutely worth attending it, because in one lecture you get a lot of confidence. So think, after 40 lectures, concept based, right, how much this confidence you'll get. This is a promo code, no need to ask to anyone. You can apply directly this promo code and you can get the direct things. For any help, you can call Pallavi, my support team. Anjali is now in Mumbai, based at Dubai. So she is the head of data flow now. Yeah, so she is the head of data flow. So you can call her for exam booking or data flow or any queries related with data flows and exam and documentation part. It's a number, two number. One number is calling and WhatsApp of India, and another is UAE calling number. She is permanently based at Dubai, now in Mumbai. So probably after next week, she will be available at Dubai. So anyone wants to contact her, directly contact her on email, mobile or WhatsApp. My number is also there, Pallav is also there. So, but better you contact directly Anjali for the data flow. So let's start. Get your pen and paper, right? Concentrate your complete things here. I expect at least 60% score, though it's not a passing score. 65 is passing overall in general, but don't try to make the score cut to cut. Try to get more 10% extra with the margin. So in exam, something goes wrong, you are easily pass the exam. So your goal is 75, but at least today mock test, I expect 60% at least, right? So let's start with this first things, picture based MCQ. A child present with the multiple discrete skin colored 1 to 3 millimeter dome shaped smooth papules on his face with central umbilication. The most likely diagnosis is verruca vulgaris, into bracket common warts, verruca plana, condylomata acuminata, and molluscum contagiosum, and keloids. So look at the picture, take your own time, right? Think over it. Also try to give the answers as well as treatment as well. So I'll give the trick to everyone how to answer. Yes, Dr. N. Dr. N, unmute your
Yes,
mic.
sir.
Yes, go
Yes, sir.
ahead. Describe this. What do you think? What is this?
I feel it is D as the answer.
D. That is molluscum contagiosum, right?
Yes.
What is this? Molluscum contagiosum is what? I mean, basically, can you tell me two, three lines of molluscum contagiosum, whatever you knows about it? Just tell me. Whatever is in your
Oh.
mind. It is bacterial
Uh,
infection, viral infection, fungal infection, parasite infection. What?
it's kind of viral infection.
Okay, it's a kind of viral infection. So, what kind of virus is involved in it?
Uh, it's, it's
What kind of virus involved in it? Yes, Toprak. You think over it. We don't want to waste the time. If you remember, you just get back to me. It's open for all. Anybody can speak anytime. Yes, Toprak. What kind of virus it is?
Technically, um, I don't know.
Fair enough. So
pox
that
virus.
so that's your homework. If you don't know, that does not solve the problem because they may ask you, you have a case of molluscum contagiosum. What could be the causative organism? So you should know. Okay. Anyone?
Pox
Open for all.
virus.
Open for all.
Pox. Pox virus.
Pox virus. How do you spell?
POX.
POX. Yes, Abhijit Chatterjee. Any Abhishek Chatterjee? Any comment? Do you think it's a HPV, human papilloma virus, Dr. Abhijit? Abhishek, sorry.
Yes, it's human papillomavirus.
So one is saying human papilloma, another is saying pox. So what's the correct? It's a common question, very, very common, not very hard questions.
Pox will be representing a similar picture, but there won't be a central umbilication.
Uh-huh. Okay, fine. So again, the question is that what virus it is? Virus name, or there is no name. It's just the hmm, caused by
Sir,
which
it's the
virus?
name molluscum contagiosum virus. I think.
Right. So that is the virus basically. So molluscum contagium virus, or shortly it is called as a MCV, molluscum contagiosum virus, MCV, right? Causes molluscum contagiosum. So name of the virus is molluscum contagiosum. No HPV, no pox. And four subtype of molluscum contagiosum virus are known and are MCV1. 98% of the cases are MCV1, is mostly seen in children, while MCV2, that is molluscum contagiosum virus 2, is mainly responsible for skin infection in people living with HIV. So don't, so you can say pox virus, DNA pox virus, sorry. So this is basically a DNA pox virus, right? So bottom line, the final answer is molluscum contagiosum can be known as a MCV1, 2, 3, 4, or it's a double strand DNA pox virus. Both are the same thing. So pox virus is the correct answer. Pox virus called is molluscum contagiosum virus, and there are four subtypes. Subtype 1 is responsible for 98% of the cases, right? And it is more commonly seen in children. So this looks like a child. So this is likely a type 1 virus, MCV1 or pox virus 1, right? So that is the things. Yes, and now what's the treatment? So you know that, okay, fine, this is molluscum contagiosum, likely 1 pox virus responsible, right? There is a papule on the face with the central umbilication. How you treat this patient? And so those who are new, while Anne is speaking, I am always interested in any MCQ multiple choice question. Three things. I am absolutely interested in diagnosis. I am interested in investigation and treatment. So diagnosis, we did it. This is molluscum contagiosum. That is a correct answer. Answer D is a correct answer, right? How you investigate, it's a clinical, right? You can see there is nobody who will doing repeated, I mean, regularly the virus culture, which is considered to be the best virus, but this is the classical case and treatment. So how you gonna treat this patient? If you have this patient comes to your OPD, patient's mother is asking about the treatment. So how you treat? Tell me. N.
So you give topical steroids,
Steroid. Okay.
ointment,
Which ointment? Give me the name of ointment.
so I don't remember.
Fine. So that's a homework. Don't sleep today night before giving me the homework. Otherwise, I will not allow you to the class next time.
Okay.
You have to put me before 12 o'clock in the night. You have to post me personally what is the treatment of molluscum contagiosum properly.
Okay. Noted.
Wonderful. Wonderful. Sorry for being a bit hard.
No, sir, no worries.
Great. Now, can anyone tell me what is can anyone identify 1, 2, 3, 4? And can you identify this? This is number 1. This is number 2. This is number 3. This is number 4. This is all 4 MCQ, different MCQ in exam. 4 different MCQ in exam. Identify this picture. Now identify. If any volunteers wants to identify. In one question, we probably covered 10 questions now. 5, 6 questions already covered. What
Fourth
is
one
pox?
is keloid.
Chalo. Fourth one is keloid. Who is this?
Catherine.
Okay, Catherine. Excellent. Keloid. 100%. Perfect. Right. 3, 2, 1. Anyone. This is exam picture. They will not give you long
Three
story.
is what size?
3 watts. Okay. Which kind of watts? Any name for the watts?
Condylum.
These 5 pictures I had given you.
Plateaus.
Just remember, this is molluscum contagiosum. Is that clear? Now this 1, 2, 3 and 4 pictures given here. So first picture is called what? Verruca vulgaris. This is Verruca vulgaris. This is Verruca vulgaris. Fix in your head. If some same pictures comes in your exam, it is a Verruca vulgaris. Second thing is a Verruca plana. Verruca plana. Right. So what is Verruca plana? So this is flat. This is raised margin. This is flat. So this is a Verruca plana. Verruca plana. This is Verruca plana. Third picture, as I told you, condylomata acuminata. So this is what the thing is. This is condylomata. This is, you can call it as a warts or genital warts. Second, and this is keloids. This is keloid. That's it. This is keloids. Right. So this is a keloid. So this is, I try to catch up all the 5 figures so you can make better understanding how they looks and feel like. Right. So this is what they comes in the exam. So they probably don't not ask you molluscum contagiosum. They may ask you something else, right? And this is what the something else is, right? So you should keep in your mind what is a verrucous plana, what is verrucous keloids, and warts or condylomata acuminata. That's it. So this is all. Again, you need to know the all treatment. I'm just trying to give you the idea, because sometimes we are in overconfident. Oh, we knows everything, right? We now my course is finished. So if you feel your score is less than 50, then your preparation is not finished. Don't take it otherwise, right? It's in general. So treatment of all 4 needs to be very well mugged up, right? It is a very common questions asked in the exam. So don't expect what I am teaching you will come in exam. Probably nearby it also comes. That is why I try to figure out a lot of things in one thing. The molluscum contagiosum classically present as a 1 to 4 millimeter dome-shaped, umbilicated and skin-colored papule. The number of lesions is highly variable, while the single papules are common, most common frequently present with the clusters of dozens of lesions. I intentionally did not posted the treatment. You need to find out treatment. Those who don't know the treatment, not just the N, everybody, you can look into the things and you can do it. That's it. Right. So that's it. Let's move. 0 out of 1 is absolutely not a good score. So you are a little behind. So let's jump to the next questions. Also little tricky. A 60-year-old woman complains of unsteadiness when walking when walking. So 60 years woman complaining of unsteadiness when she is walking. On examination, she has a pyramidal weakness of left lower limb pyramidal weakness. and reduce pain and temperature sensation on the right leg and right side of the trunk up to the umbilicus. That's on the opposite side. Left side, understand, don't mug up. Left side, weakness. Right side, what's there is a sensation, temperature and pain. Reduced pain and temperature sensation on the right leg. That was on the left leg. And it is on the right trunk up to the umbilicus, up to the umbilicus. Joint position sense is impaired at her left great toe, but is normal elsewhere. She has a definite left extensor plantar responses and the right plantar responses is equivocal. Where is the lesion? Left cervical cord, mid cervical mid thoracic cord, left mid thoracic cord, right mid thoracic cord, left lumbosacral plexus. Again, think, take your time. We are not in hurry. What is the diagnosis? What is investigation? What is treatment? So until and unless you know little bit clue of diagnosis, it's little difficult, though it's not tricky, difficult questions, but it looks difficult because you don't know. Yes, Toprak, any idea? Catherine?
Unfortunately, I have no idea.
No idea, no problem. Yes, Catherine.
Sir, even I have no clue.
Okay. Dr. Ajdani, any idea, sir?
Not exactly, sir.
Any guess?
I
Don't
think
worry.
it's
Something wrong where?
left hand.
I mean, just think. Don't worry. Just think where could be the problem, first of all. There is a problem.
It's a
Perimeter, brain, spinal cord, blah, blah. So where's the problem?
spinal cord, sir.
Okay, spinal cord.
Spinal.
You are absolutely perfect. Spinal cord. Now, where
It's a
could be a spinal cord at what level?
mid thoracic cord level. It's
Mid
a
thoracic.
option B.
Option B. That is midline mid thoracic cord. That is,
Brown-Sequard syndrome, I think, sir.
it's a Brown-Sequard syndrome. So what is Brown-Sequard syndrome?
It's
What happens
a
exactly?
spinal cord lesion in the spinal cord.
Sorry, what happens in the spinal cord?
Lesion.
Okay,
Lesion.
lesion in the spinal cord.
Hemisection of the spinal cord.
Hemisection of the
Yes.
spinal cord. So right-sided hemisection or left-sided hemisection?
It would most
Actually,
probably
the
It could be
effect
both sides,
would
nah?
be in the contralateral side,
It could
sir.
be right.
So it could be right. Hemi means half, right? What I understood. So hemisection is on right side or hemisection on left side? So that
I
is
think,
one question. And
option
second
C-
question is
option
that
C.
Right side, sir. Right side.
right side. Okay, anyone else? All
No,
agreed
it
with
will be
right?
left side, sir. It will be left side
So
section.
what's the answer, Abhishek?
So C, left mid thoracic
C
cord.
is the answer. C is the answer.
C is the answer. Left mid thoracic cord. Right. So what are the causes of this Brown-Sequard syndrome, Abhijit?
Sir,
What causes?
trauma can be a factor.
Excellent. First is the most important is trauma. Gunshot wound, right? Maybe,
Yes.
or injury, or ischemia, or infection. This is what I evaluated by my studying this slideshow when I was preparing. So this is the picture, right? So this is absolutely a Brown-Sequard syndrome. So look at the things, right? This is a spinal cord. This is a picture of spinal cord, though may it's a little less. So there is a anterior cord problem. There is a cortical cord, Brown-Sequard syndrome, right? So if I can little enlarge, let me try if I can able to enlarge. Just to make you better understanding. Is it visible little better?
Yes.
Yeah, so what is the Brown-Sequard syndrome? It is a penetrating trauma. So this is a brain, this is a spinal cord, right? If you can see the picture and my cursor, right? There is a ipsilateral loss of motor. Ipsilateral means same side. Contralateral means opposite side. So ipsilateral loss of motor, vibratory sensation and proprioceptions with the contralateral loss of pain and temperature sensation. So this is classical case. This is classical case, right? So ipsilateral, again, ipsilateral means same side. Whenever you have right, say for example, right hemi injury, right? Or right cord this compression, sorry, right cord injury, right, right hemisphere, there is a ipsilateral means same side loss of the motor means movement, motor muscle movement, right, vibratory sensation and propriosensation with opposite side contralateral loss of the pain and temperature sensation. Prognosis is overall good, let me tell you. And what are the causes? As I told you, causes, right? So cause is this: trauma, gunshot wound, stabbing, spinal cord tumor, ischemia and infections. Because of anything, right? If it is causing the spinal injury, same side, ipsilateral side, there is a loss of this motor and vibratory sensation, and opposite side, contralateral side, there is a loss of pain and temperature. That's it. So this is called as a Brown-Sequard syndrome. Brown-Sequard syndrome. Discard. Fair enough. So that's it. So no need to mug up. Just remember. So answer is left mid thoracic syndrome, right? So answer is C, left mid thoracic cord, right? A problem. So in this you get this classical things, right? So go and read it once again. This is very, very important. And treatment is what? Treat the underlying cause. If there is a trauma, you treat the primary things. Spinal cord tumor, you treat the tumor. Ischemia and infection, you treat same way, right? So Brown-Sequard syndrome is very frequently asked question in exam. Still, if you have confusion, go and read specifically Brown-Sequard syndrome or left or mid thoracic this spinal cord injury. That's it. So third question in front of your screen, 1 out of 2 is okay score, 0 out of 2 is not good score. A 64-year man has recently suffered from acute myocardial infarction and is on aspirin, atorvastatin, ramipril. He has been having trouble sleeping and has been losing weight for past 4 months. He does not feel like doing anything he used to enjoy and has stopped socializing. He says he gets tired easily and cannot concentrate on anything. What is the most appropriate treatment for this gentleman? Your time starts now. Get to the basic. What's the diagnosis? How you investigate? How is the treatment? They're directly asking you the treatment. But by my sense, without making a diagnosis, it's very difficult to think of treatment. So first think of diagnosis. What could be the diagnosis? Yes, Catherine.
Sir, I'm thinking depression here.
Depression here. Minor depression, major depression. Or any
This would be,
differentiate?
I don't know how to differentiate, sir, but I'm guessing major because he's having sleep is disturbed, appetite is also lost, there is no concentration, socializing skills are also come down. So mainstay treatment will be SSRIs or SNRIs, so fluoxetine.
So what is SSRI and what is SNRI full form? Catherine.
Uh,
What is the full form? SSRI, SNRI. 1 minute, one by one. I'll come to everyone. Don't worry. Just give her time. Give the Catherine time to think. We are not in hurry.
Sir,
We'll discuss everything.
selective serotonin reuptake inhibitors, that is SSRIs.
Okay, great.
So citalopram will come in that.
Okay. And SNRI?
SNRI is selective.
Fair enough. Don't worry. This is homework. This is homework. Whatever you don't know is a homework. 100% it will come in exam.
Serotonin and norepinephrine. I
N
forgot,
stands
sir.
for what? Just tell me what is N stands for what? SNRI. N stands for what? That's it. Simple question.
Norepinephrine.
Non-selective.
Fine. No problem. What is the difference, Catherine, between SSRI and SNRI? Is there any difference or just the name is the difference?
No, sir. The mechanism of both the drugs are different.
Okay, so what's the difference? What's
Um,
what's the difference? There must be some difference, no? Dr. Badris, any
the
comment?
difference between the
Yeah, you think? Tell me, you go ahead, you continue. I'm speaking with Dr. Badris. You speak up, Catherine. Yes, Badris, any comment?
Yeah, the one is a selective serotonin reuptake inhibitor, and the other one is a selective noradrenaline, I think, uptake inhibitor.
Okay, so how do you think, sir? How it change the mechanism of action, or which one is better over another, or is there any change in the effect and side effect profile? What's your thought process?
Yeah, I think the serotonin, it is different. The one obviously blocks your serotonin, and serotonin is partly related to the depression pathways, and the noradrenaline has a different pathway as well. Side effect profile is also different. I think the
Okay,
one,
so which one is
um,
better? If you have selection between in depression patient comes to your OPD, you have selection, sir. You have all the opens drugs are open for you. SSRI, SNRI. Which will you select? Number one, SSRI or SNRI? Number one.
I think as per from what I remember from the guidelines, I would go for the SSRI, and depending on how the patient responds, you would adjust accordingly. Whether there's tolerance, weight gain, etc. So you'd look at that profile and then
Fair
adjust.
enough. Fair enough.
But I would start with SSRI.
SSRI. Wonderful. Can you name some SSRI?
Yeah, I think the citalopram, the C, is an SSRI,
So only one drug you know, citalopram.
and um,
fluoxetine.
fluvoxy, yeah, D as well. Sorry, D as well.
Fair enough. Fair enough. Fair enough. Fair enough. Fair enough. Okay, so what is the commonest side effect you come across if you used in your clinical practice? What side effects you came across for this all SSRIs? In general, I
For
mean, every
in
every
gen,
drug
I
is
think
little different, but in general, I
it,
mean,
yeah, unfortunately, the one that just in practice, the weight gain with citalopram is quite common. I'm across that quite often, actually.
fair enough. So, are you a physician or what? I mean, your specialty?
I'm a family physician,
Fair enough.
specialist
So,
family physician.
probably great, wonderful. Hopefully, is it your first class?
No, I've been attending a few of these. I'm just waiting for my outcome for whether I'm going to be needing
Wonderful.
an exam
So,
or if I'm
are
going to
you
get.
enjoying my
I'm
classes?
enjoying every class. Thank you. Yes,
Excellent. Wonderful. Wonderful. So, please post one review later on. Excellent.
certainly.
Excellent. So in general, sir told properly well, but we need to be more precise, right, for the drug, right? So let me give you a little more idea, right, about this insight of this thing. So obviously, Catherine, you are absolutely correct. This is a depression case, right? How you know the depression case? Because patient has acute MI, so after MI he may went into the depression. God knows because what happens to me, blah blah. And after MI, he is already on the drug. What is Ramipril, Catherine? Ramipril is what? It's drug
A
mentioned Ramipril.
AC inhibitor, sir.
ACE inhibitor. What's the side effect?
Tachycardia. No.
Dry
Cough.
cough.
Dry cough.
Chronic cough.
Right.
Yes.
Cough. So cough is an important side effect, right? So you try to avoid in a COPD patient as far as possible. Not bad, but still, I mean, if you have another options, try to, because COPD already obstructive disease, and top of that, this causes this all again histamine release and blah blah. So again aggravating the cough. So is pril is all is ACE inhibitor. Captopril, enalapril, lisinopril, perindopril, ramipril. So this all pril suffix is a ACE inhibitor, right? And ton is a ARBs, ton. So same time your pharmac is getting little revised, right? So losartan, telmisartan. So all ton is a ARBs, angiotensin receptor blockers, right? This is ACE inhibitor, angiotensin converting enzyme inhibitors, ACE1, 2, right? So go a little check it pharmac. So this is, you must know. So this patient has a trouble sleeping, number one, losing weight, number two, and that is not for 1 2 days, it's a 4 months now, Third thing is he stopped socializing, is like a little depressed, right? So he can't. So whenever this is very common, I have seen in my medico friends, they are stopped socializing. I don't know whether they have depression or not. God knows. But there are a lot of people, they try to avoid, right? So try to get socialized with your family friends. It's good way of counteracting the depression, right? To try to mingle with them. So it's a natural way, right? So what now? This is a depression. Now the concern is somebody who has a recent acute MI. Which drug could be the safe to use in acute MI, recent case of recently suffered acute MI? So you need to have two things. One is you need to have antidepressant drug which is safe for the heart. So name the drug from the list which is safe for the heart, and that is citalopram. Right. So the answer is citalopram. Right. Citalopram. Is that clear? Right. So go and read once this antidepressant. It is very interesting chapter. I love it. Right. So this is citalopram. Amongst SSRI, that is selective serotonin reuptake inhibitor, sertraline is the drug of choice for IHD. So if you have a sertraline in your option, which is not there unfortunately, if it is there in the option, it is one of the safest drug. S for SSRI, S for sertraline, right? So sertraline, SSRI, SSRI, sertraline, sertraline, SSRI. So this is considered to be the one of the safest drug of choice for IHD or ischemic heart disease, coronary vascular disease, coronary artery disease, all are the same name. Next choice is a citalopram. Citalopram, right? And one bad thing is, as it's often related with torsades pointers, torsades pointers. So you must know what's the again question. What do you mean by torsades pointers? So go and read it. We'll sometimes cover in next couple of lectures in cardiology with ECG torsades pointers. If SSRI cannot be used, then if it is contraindicated, they mention scenario mention that you cannot use SSRI for this depression patient who recently got acute MI. What the next? Then mirtazapine is recommended as a next antidepressant. So three answer in one question. They have asked best. Sertraline is the best. If it is not in the options, then second is citalopram. If SSRI is contraindicated, then mirtazapine is a drug of choice. That's it. So this is what the thing is. Now let me come to the SSRI and SNRI, Catherine. Dr. Badresh, right? So SSRI is referred to an antidepressant that inhibits the reuptake. The name itself, right? The selective serotonin reuptake inhibitor. So what is the inhibit? It inhibits the reuptake of serotonin in the brain. That's it, simple. The name itself suggests selective serotonin reuptake inhibitor. So it prevents or it inhibits the serotonin in the brain. That's it. Here SNRI refer to an antidepressant medicine. This is also antidepressant medicine. Acts on a neurotransmitter of brain that affects the person's mood. So it acts on the neurotransmitter. What inhibits? It inhibits just the serotonin. What it inhibits SNRI? It inhibits both. There are two things, serotonin and norepinephrine. Two things. N stands for norepinephrine. So selective serotonin reuptake inhibitor, you can say selective serotonin and norepinephrine reuptake inhibitor. In my language, instead of SNRI, SSNRI. Selective serotonin and norepinephrine reuptake inhibitor. So SNRI and SNRI, just to make it easy, right? This is selective serotonin, so this is serotonin plus norepinephrine. That's it. So it inhibits the both reuptake in the brain and try to alleviate your mood. That's it. So that's it. This is what the thing is. And this is also used, this SNRI used to treat the major depressive disorder, anxiety disorder, mood disorder, and ADHD. And this SSRI used to treat the moderate to severe depression, anxiety, panic disorder, OCD, obsessive compulsive disorder, PTSD, post-traumatic stress disorder. Because of the toxicity profile of SSRI, it is widely used clinically, right? With the less interactions with the drug, better this safety profile as well. SSRI causes less severe side effect compared with the SNRI. SSRI is more tolerant, which is less tolerant because of side effect, and it is less cost effective, cheaper drug compared with SNRI. So that's it. This is what the head-to-head comparison for your knowledge. So I try to make it more simplified. I'll share with this slideshow and video in the evening, so you can go through it once again. That's it. So 3 out of 3 is excellent, brilliant score. Less than 2 is not good score. That's it. So these are the few side effects, not going much in detail. You can review later on. Next questions in front of your screen. Which of the following antibiotics will cover methicillin resistant Staphylococcus aureus, that is called MRSA, MRSA, MRSA is methicillin resistant Staphylococcus aureus. Is it nafcillin? Is it cefazolin? Is it piperacillin tazobactam? It is ceftaroline? Is it azithromycin? Take your time. Yes, Neelam, any comment, Dr. Neelam? I want to hear from you.
Yes, sir.
Good morning. Is it okay to interact with me?
Yes, sir.
Wonderful. Go ahead. What is MRSA and what is MSSA? Have you heard of this word or not yet?
Yes, sir. I've heard, sir.
What is MRSA? What is MSSA? Tell me.
Yes, sir. So this is basically, sir, it's a staphylococcus infection, methicillin resistant,
Okay.
caused by the staphylococcus bacteria, sir.
Okay. Is it gram positive or gram negative? Staphylococcus is.
It's gram positive, sir, I think.
Gram positive. So can you tell me 3-4 names of gram positive? One is Staphylococcus. Second? Yes. Only.
Streptococcus.
No, streptococcus is negative.
Okay. So Streptococcus Neelam is negative or positive?
Positive, of course, positive, sir.
Just let her answer.
Cocci, all the cocci are positive, I think.
Positive, sir.
Okay, fine.
So
Now it's a Neelam's term. I will come to you, Dr. Ajidani. Yes, doctor. So one is a Staphylococcus, Dr. Neelam.
I think enterococcus.
Second is a Streptococcus. What else? Any other gram positive?
Enterococcus, sir.
Enterococcus. Are you sure? Or just because of coccus it is gram positive?
Yeah.
I think so.
No problem.
Nigeria.
Dr. Neelam, again your turn. Gram negative. Tell me 3 names.
Gram negative.
Another name is GNB, gram negative bacilli.
Right, sir.
Or gram negative bacilli. GNB is a book term. So tell me any 3 name which you knows that, okay, sir, this is gram negative.
Gram negative, sir, is
Sorry?
Neisseria, I think. Neisseria.
Neisseria, directly Neisseria. Okay. We didn't find out easier one.
Gonorrhea, I think.
Gonorrhea. What about E. coli?
Yeah. E. coli is. Yeah, E. coli is.
What about Pseudomonas? What about Klebsiella? So your homework, Neelam,
Yes, sir.
to give me the 5 names of gram positive and give the 5 names, not 3 names of gram negative.
Okay,
And what
sir.
is the importance of gram positive and gram negative? Are you okay with the homework?
Yes, sir. I'll do that. Yes, sir.
Right? You need to find out, open up the microbiology, right?
Yes,
Try
sir.
to reduce the rest on Sunday because I'm also not resting in spite I'm not giving any exam. I prepare whole week, then I can able to present this 2 hours. You can
Right.
understand my feeling.
Yes, sir.
Fair enough. So what do you mean by MRSA? How you classify the MRSA, Neelam? Sorry, this question is for you only. Don't take it
Yes,
up.
sir.
So what do you understand by methicillin resistance? Means methicillin is what? Methicillin is what? So methicillin is, Dr. Neelam, it's a drug name like levofloxacin, doxycycline, Septran,
Yes.
azithromycin. It's a drug, methicillin sensitive and methicillin resistant Staphylococcus aureus. Why we
Right.
need to figure it out? Because in a clinical setting, the methicillin resistant Staphylococcus aureus present with the more bad features. They present with the poor prognosis. They present with something more morbidity and mortality. You understand? So
Right.
we
Yes.
need to classify that. Okay, fine. This is first of all Staphylococcus. One is sensitive, one is resistant. Resistant is something which is not responding to methicillin. This is how it classifies, right? Like
Right.
gram positive and gram negative, they all are bacteria, bacilli, but depends on how they stain, right? Right, under microscope, right, pink color or blue color, they called, okay, this is gram positive, this is gram negative, just to differentiate them, right? So
Right.
this is a methicillin resistant Staphylococcus aureus, right? So methicillin resistant, where this Staphylococcus commonly, right? So have you ever seen in your clinical practice MRSA infection in your hospital or in ICU? Or not yet? Where the
No, no,
report, where the report comes, the blood culture we draw and blood culture isolated MRSA. Have you seen such a report in your practice or not?
no, sir, no, sir.
Fair enough. So now you have MRSA. What do, forget about this A to D options here. Give me the three name of the drug which is sensitive against MRSA. Or if MRSA comes, right, in a blood culture positive or sputum positive, right? So antibiotic you used to use for this patient, I mean to treat this patient, what antibiotic you can think of in your mind when somebody tells me, Dr. Munjal, your patient is a febrile neutropenia and isolated MRSA. So irrespective of sensitivity report, I have something in my mind that I'll use 1, 2, 3 in this patient. What's that? Anyone? Now open. You think, Neelam, mean in between? Right? It's a very practical questions in the clinic. It's a commonest cause of morbidity and mortality in the ICU, right? Yes, anyone open? Anyone wants to comment?
And
Sir,
one
we
one
use
of the
vancomycin
One by one.
or cephalosporin, and if vancomycin is not available, we can use linezolid.
Okay, fair enough. Fine. So these are the few drugs. So can any volunteer? What is nephicillin? Anyone? What is nephicillin?
Nephicillin is beta-lactamase resistant penicillin. It's same methicillin, same group.
Okay,
yes,
so
it's an ampicillin group of medicine.
okay, so this is nephicillin. So can you tell me where the nephicillin is exactly used? What's the indication of nephicillin? Fair enough. This is the homework. This all questions my brother, sister come in exam, so don't neglect it. Right? I'm not here to just mug up you the few questions and I'll run away. I'm trying to give you the basic knowledge which will help you for hundreds of answers you can answer if you understand the logic. So nephicillin, you must remember what kind of drug it is, penicillin or cephalosporin. Number two, how it acts on the bacteria. Number one, and what are the main indication. And fourth thing is, what is the commonest side effect of nephicillin? You must know. Everyone should post the answer. If you are sincere enough, you post the answer in the group, in our August free mock test group, so people will also learn and understand. Second thing is cefazolin. What is cefazolin?
It
Catherine,
is
what is cefazolin?
cephalosporin.
Yeah,
Cephalosporin, sir, first
it's a
generation.
cephalosporin. How many groups of cephalosporin? 1, 2,
Uh,
3, 4, 5, 6,
five,
7, 8, 9,
five
10.
generations.
Somebody is saying 4, somebody is 5. I'm saying 7.
Three. Sorry, five.
5
5.
generations.
So no 6 generation.
I don't know about 6, sir. I know only 5.
No, it's 5. I mean, I'm just trying to understand. If somebody is more advanced and 6th generation will come. Okay,
Five line, ceftrolin, ceftopiprol, and ceftolozane.
fine. Catherine, your turn. Catherine.
Sir,
No,
first,
1 minute, my sister, hold. First generation cephalosporin, one example.
Cefazolin, sir. Cefazolin, cephalic.
Cefazolin.
cephalic.
1 minute, dear doctor. First generation is cefazolin. Second generation,
Cefotetan, then cefuroxime, um,
are you sure?
cefuroxime. Yes, sir.
Third generation
Yes.
cephalosporin.
Ceftriaxone, sir. Ceftriaxone is there.
Fourth generation
Ceftriaxone.
cephalosporin.
Here one.
Cefepime.
Sorry,
Cefepime.
cefepime. Absolutely correct. Absolutely correct. Cefepime is a fourth generation. Fifth generation,
Ceftarolin.
everyone should know. Can anyone tell me why this generation comes in the picture? What is difference between first generation, second generation, third generation, fourth generation, fifth generation? What's the logic of these generations? Anyone? Anyone? What is it? Why somebody thought of, oh, now come with the second generation, come with the third generation, come with the fourth? Why there is a no one generation? All the drug in one generation. That's it. Why we need to make medicine more complicated, first and second and third and fourth? Is there any difference? Is there any logic of what do you mean exactly by the generation? Anyone?
The gram positive and gram negative coverage.
Sorry, doctor.
Gram positive first generation will cover the gram positive, and third, fourth, five, and it's more cover the gram negative.
Okay, so basically what understood from your talk, the generation, I mean, higher the generation, more the coverage would be, isn't it?
Yes, sir.
Yes or no?
Yes, sir.
Right. So why the generation came in the picture? First generation probably cover less organism. Second generation like little more organism. Third will be more. So more species plus more resistant bacteria can also be covered when the generation advances, right? So that is why it is important. Like first, you must have heard in mobile, right? 1G, 2G, 3G, 4G, 5G. Have you heard of this or not? Yes or no? 5G network. Have you heard of it or not?
Yes, sir.
What do you mean by 5G? So 5G means, right, fifth generation net is like more faster, right? More faster, more coverage. Same way, the generation, first generation, second, third, fourth. So everybody should know the what are the 5 generations of cephalosporin and what exactly they covers. That's it. So this is what the homework for everyone, right? Any questions come from the exam, not just what I am explaining you, right? So here, what is the answer? Here, what is the answer? What is the Neelam? What is the answer here? Finally, what's your answer here? MRSA, right? Antibiotic coverage. Any clue, Neelam? Yes, Neelam. Are you there? You're not there. Dr. Uttara, any comment? Dr. Uttara, any comment?
Yeah. Ceftaroline.
Sorry?
Ceftaroline.
Ceftaroline. So ceftaroline. So just concentrate on antibiotic. It's very important, especially in clinic while you are dealing directly with the patient. I don't want you to be a pharmacologist, but at least you must know the basic things. So what is the cephalosporin, ceftaroline is the most advanced fifth generation cephalosporin, right? Gram negative bacilli and MRSA. It covers the GNB, that is gram negative bacilli, and MRSA, MRSA, methicillin resistant. But if they ask you Pseudomonas, is it cover? Then it does not cover the Pseudomonas. So when you are treating the Pseudomonas, ceftaroline is not a good drug of choice. Why? Because it does not cover the Pseudomonas, while it is a drug of choice for MRSA and gram-negative bacilli. That's it. So this is what the thing is. Is that clear?
Yes, sir.
And this is the things. Here there are two type of Staphylococcus aureus, as I told you. methicillin sensitive and methicillin resistant staphylococcus, and in methicillin resistant there are two, community acquired and hospital acquired MRSA. It's very common in clinical practice. Community acquired and hospital acquired staphylococcus aureus, which are resistant to methicillin, which carries high morbidity and mortality as well. So you need to promptly treat it, isolate it, and do the things. These are the list of the drug, MRSA drugs, right? Or anti-MRSA, which acts against methicillin resistant staphylococcus. Ceftaroline, it's a fifth generation cephalosporin. These are the first line of agent can be used and considered in clinical practice. So whatever comes in the options, you can opt for and give the answer. Dalbavancin, another is a daptomycin, linezolid, oritavancin, then tedizolid, telvavancin, and vancomycin. So what we usually clinically used very frequently is the fifth generation cephalosporin, linezolid, and vancomycin. It is commonly available commonly available drug across the globe. This all drug probably may or may not be available, but these are we use very frequently in our hospital and clinical setup, especially neutropenic patients, post bone marrow transplant patient with MRSA resistant in blood culture or bacteremia with the Staphylococcus aureus, right? So we first use vancomycin if not used, and linezolid, and then ceftaroline. So this is how we used, right? So that's it. Is that clear, Neelam? 4 out of 4 is a brilliant score. 4 out of 2, 2 out of 4 is average score. 62-year-old woman with a metastatic breast cancer includes bone metastasis present to the accident and emergency with sudden onset of back pain, difficulty in walking, and urgent MRI of spine suggests and confirms the cord compression at the level of lumbar 1 and lumbar 2 spine. What is the most appropriate initial management of this patient? Surgical decompression of spinal cord, dexamethasone, radiotherapy or RT, chemotherapy or physiotherapy to this patient. Let's try these questions. I wish everyone post the answer. Yes, Kaushika Kalai, would you like to comment on this? Any comment? Kaushika Kalai.
In order to relieve the inflammatory changes, we give dexamethasone. If there is some autonomic dysfunction, then we go for surgical decompression of the spinal cord.
Okay, so your answer is a dexamethasone, right?
Yes.
Okay, so what is dexamethasone?
Steroid.
Which steroid? Glucocorticoid. Okay, so you give orally, intravenously, subcutaneously, or intraspinally?
No, intraspinally. I give IV. IV.
You give IV. Okay, so after giving IV, how does this patient will get benefited?
This will result in relieve inflammatory changes because of cord compression.
Okay, so that inflammatory basically, so compression will reduce. What do you think? There is a cord compression. There is a cord compression, isn't it? Because the word is written clear cut here, right? There is a confirms the cord compression at L1 and L5. So this is a spinal cord. Say for example, this is L1 and this is L2, right? So spinal cord is going in between, right? So because of some metastasis, there is a cord is compressed here. So what will you do immediately to decompress? Compress to decompress. What will you do? You give the dexamethasone. So dexamethasone, that's the answer. So dexamethasone is a steroid basically. It is a glucocorticoid. Steroid has a property anti-inflammatory, isn't it? Yes or no? Anti-inflammatory. Inflammation is Anti means opposite the inflammation. So inflammation has 5 things: pain, fever, right? Swelling, loss of temperature, and functions, blah blah, right? This is all basic principle of inflammation. So whenever there is an inflammation, whether it is in the tonsillitis, pharyngitis, bronchitis, appendicitis, cystitis, there is inflammation. Itis is an inflammation, isn't it? Yes or no? Itis is an inflammation. So anywhere is an inflammation, you have some kind of pain, fever, swelling, loss of functions, blah blah. So because of the compression, right, patient has what? Present to emergency with back pain. So pain is there. One of them is pain, inflammation, loss of functions, difficulty in walking. That's confirmed by the MRI. So you need to reduce this inflammation in L1 and L2. The fastest, the cheapest, the easiest, and most convenient way is to give the steroid. That's it. This is how we do. This is our day-to-day job in oncology, because there are lots of patients who present with the cord compression. We called as a cord compression. Have you heard of corda equina syndrome? Yes or no? So cord compression. Have you heard? Right? So,
Yes.
right. So dexamethasone is the first treatment. You give this to the patient, steroid. After that, think of second immediate treatment is a radiotherapy, which is non-invasive. You just give the radiotherapy to the back and spine where the metastasis is there because of breast cancer. And if does not improve, then third, you go for the surgical decompression. That is the first option, right? So first is a dexamethasone, that is option B, right? Then radiotherapy, that is option C. And if does not, then option A, that is a surgical. Chemotherapy will not act immediately, and physiotherapy will not open up the metastasis, or it will not reduce the inflammation immediately. So you need something which is fastest, easiest, immediately done, and that is steroid. So you give steroid, right? 8 milligram twice a day or so, right? Look at the improvement neurologically. If the inflammation reduces over 24-48 hours, continue the steroid. If no improvement, then refer to the radiotherapy, because radiotherapy will immediately decompress the spine, right, after giving the radiotherapy. So this is how we need to do in clinical practice. That's it. So this is what the classical case of cord compression. Lots of patients, especially the oncology patients, present with this. And let me tell you, this is a oncological emergency. Like acute myocardial infarction is a cardiac emergency, stroke is a neuro emergency, acute pulmonary embolism is a pulmonary emergency, cord compression is an oncological emergency. You need to treat promptly, otherwise there is a paraplegia. A 17-year-old boy suffered a generalized seizures at a school and is brought to the accident and emergency by ambulance. His teachers reports that he has well during the day but has suffered from the repetitive ear infections, and despite taking the antibiotics during the week, still suffered from the headache and ear discharge. On examination, he appears well but complain of headache. His temperature is 39 degrees Celsius, is neurologically intact. A CT scan confirms the cerebral abscess, and rapid culture test confirms the streptococcal infection. The most appropriate management is cefuroxime alone, cefuroxime and metronidazole, flucloxacillin alone, fluclox plus cefuroxime, and surgical decompression. It's kind of neuro case. This is the picture. This is a picture of cerebral abscess. This is cerebrum, and there is a abscess, cerebrum abscess. Yes, iPhone. I don't know who is the iPhone name on the iPhone. C or D, option C posted. Can you speak up? Yes, Dr. Onkar. Any comments, sir, in your clinic, how you manage this? Okay, no worries. Got your point. You are unable to speak, sir. I am at work. Fine, fair enough. I'm happy at least you joined. Yes, Onkar. Dr. Harry. Dr. Harry.
Sir, I confuse between metronidazole and flucloxacillin, but I remember it's a fluclox and cefuroxime.
So why do you think it is D? Why not B? Because abscess doesn't contain anaerobic things.
Okay, sir.
No, I'm just trying to understand the concept. So have you done any duty in ICU or neuro ICU or stroke unit, sir?
Sorry, sir.
Have you ever done the duties in ICU, neuro ICU, high definition unit or stroke
Yes,
unit?
sir.
So
Yes, sir.
you may have many cerebral abscess. What do you think? Or you have not come across any cerebral abscess so far?
Cerebral abscess we have come across, sir, but metronidazole I didn't see much.
Fair enough. So what is metronidazole basically? What kind of drug it is? Because this is the one of the highest drug people use across the globe, metronidazole.
It is nitroimidazole. It destroyed nucleic acid.
Sorry?
Metronidazole and nitroimidazole group,
Okay.
and is destroyed. Is affects to DNA
DNA of what?
DNA synthesis.
Sorry, DNA of what? Which
Nucleic
organism?
acids. Nucleic
Nucleic acid.
acid synthesis effect.
Okay. What is the commonest organism targeted by metronidazole? So you give the metronidazole to which kind of patients where you usually love to use metronidazole? Example,
Yes, anaerobic.
anaerobic. How do you
And
know? How do you know before doing the anaerobic? How do you know that this is anaerobic? So one patient comes to your clinic saying, I have a profuse diarrhea. What is the drug of choice you will use?
actually, we give large
Because
line antibiotics. Cefuroxime affect gram positive, metronidazole gram negative is anaerobic. We give large effect.
so this all drug, I mean organism like streptococcus, staphylococcus, E. coli, right, anaerobes, we get to know once we isolate them, ne? Once we isolate them, when we know, ne? When somebody is doing coughing, how do you know which organism it is inside the chest or in the sputum? Until and unless you do the sputum culture, how do you get to know? So my question is that in clinical background, without doing any investigation, where you supposed to use the metronidazole? What kind of patients? What are the indications of using metronidazole? Anyone, open for all, anyone. In general, na? Because it is very commonly, it's a GP drug.
So metronidazole
Related
have
with the GI.
great gram negative coverage, sir, and we
Gram
are
negative.
using yes, and
Okay.
we are using metronidazole in case of helminthic infection also. It's an anti-helminthic drug.
Okay.
And then that's it, sir.
So only one indication, only enthalmentic
So
you
for
can use.
GI,
So we have
for
lots of
GI,
indication here, sir, but
Yeah,
as
so
a
you
whole,
tell
we
me,
can
na,
say
two, three, tell me, na. Two, three, tell me.
like
One is anti-helminthic, right? So all
yes.
worms basically, right? You want to use metronidazole for all worms?
No, sir. We have separate indication like
So give me the indication in general. Sir, this is the one indication. This is
yeah,
second.
metronidazole we can use in this Trichomonas vaginalis, like
Okay,
Trichomonas
Trichomonas
vixi.
vaginalis. Okay, fine.
Yeah,
Then that is
Then
one.
we can use in case of the diarrhea if we are suspecting it is a gram negative kind of. Then
Okay,
we
second.
then we can use this one.
Third one is Trichomonas. Second is diarrhea. Third one is
Um,
So it looks easy, but it's difficult question, isn't it?
Fragile
Right.
left
Common in
cilia.
infections, sir.
So I don't want you to miss my friends metronidazole, highest prescribing drug across the globe, especially in Asian countries where there is a diarrhea is a common problem. Metronidazole, you cannot live in India without metronidazole. Every other patients in ICU, in the ward, in the critical patients, neutropenia patients, septicemia patients, metronidazole is going. So you must know what are the indications of using metronidazole. So it is a homework for each and everybody, not just to mug up the indication, but go through the literatures, basic literature. What is metronidazole, Guru? What under it falls under what classification of the drug? What is the mechanism of action and what box it covers and what's the clinical indications of the matter. It's a very, very, very common drug. Irrespective of they ask in the exam or not, you will going to prescribe in every other patient. So you must know the indication of metronidazole, right? So stretch yourself little bit on Sunday, right? Here the answer is cefuroxime and metronidazole. Or cerebral abscess. Listen, cerebral abscess is one of the most dangerous complications that can result from infections affecting the face, right? So face directly goes to the brain, right? Just they have to pass the plate, right? Face and ear infections, and it goes to the brains. Sinusitis, otitis media are the commonest ones. Sinusitis, just only one plate, cribriform plate directly goes into the brain, cerebral abscess. Otitis media, inner ear directly goes to the brain. So these are the two common. So you should not have, neglect the sinusitis and otitis media. Why? Because the complication of both the condition is a cerebral abscess. Patient can complain fever, headache, seizures among other presentation. Stable patient, like this patient, stable patient. Pharmacological therapies depend on the suspected organism, right? So depends on what organism is there you're going to gonna treat this infection, right? For staphylococcus, for streptococcus and anaerobes, intravenous cefuroxime. Can anyone tell me which generation cephalosporin is this? Cefuroxime. You need to do practice of this every day. Which,
second,
sorry? Second generation cefuroxime and the metronidazole are required. Staphylococcus infection requires intravenous flucloxacillin, which is not the case. In general, staphylococcus infections are more common in the abscess, right? Cefuroxime A and fluoxetine alone are not adequate treatment. Surgical decompression is required in the patient who are unstable or have remained refractory to the antimicrobial therapy. So bottom line is that whenever there is an abscess, commonest is anaerobe and commonest is staphylococcus. Give the combination of both, which covers the both, which contains the metronidazole. If you don't have the response to the conservative treatment after 3 to 5 days considered, or patient neurologically worsening, or patient is unstable, open up immediately without giving the course of antibiotic. But in stable patient, you must always try for IV antibiotic. That's all. Still, homeworks remains there. Metronidazole indication. 35-year-old woman complains of sharp central chest pain that is acutely exacerbated each time she moves, breathes in, or lies flat. The pain tends to stay in the center of the chest but occasionally moves towards the neck and shoulder. The pain is relieved by the sitting forward. Patient does not drink alcohol, is not diabetic and not a smoker. A pericardial rub is heard on the auscultation. The most appropriate diagnostic investigation is CT calcium score, EKG or ECG electrocardiogram, serum amylase looks like pancreatitis, chest X-ray and echocardiogram. Your answer would be most probably wrong if your diagnosis is not correct. So first diagnosis.
pericarditis,
Think over it. 10 seconds.
pericarditis,
Think over it. 10 pericarditis. So who is saying
Diarrhea
pericarditis?
present. Yes, me, sir. Because the
Ajlani.
pain
Okay,
is
so
relieving
1 minute, sir, 1 minute. So your answer is a pericarditis, right?
constructive pericarditis. Yes, sir.
Okay, fine. So now give me the point which favors the pericarditis from this scenario. That
Sir,
sir,
the
this is pericarditis. Now tell me.
pain is relieving on sitting forward. Pericardial rub is
1
present.
minute. Where it is written that pericardial rub is heard on auscultation and chest pain is relieved by
Pain relief on sitting forward.
okay, pain is relieved by sitting forward. Okay.
Okay. And then, sir, the move the radiation of the pain towards the neck and shoulder. These 3 points.
Okay, so what is this? The patient has a sharp central chest pain is acutely exacerbated, means increased each time he moves, breathes in or lies flat. So in this condition, pain increased, right? And
Yes, sir.
it tends to be center of the chest, right? And it also moves toward neck and shoulder and relieved by sitting forward. So what kind of pain it is? What's the diagnosis?
Constructive pericarditis for me. And there
Constructive
will be a,
pericarditis. Okay, how you diagnose the, I mean, what are the investigation of choice for constructive
so we'll do
pericarditis?
the ECG.
Okay, so
And
what you find in ECG, sir? This is all question in
saddle-shaped
exam. Yes, tell me.
saddle-shaped PR interval, like high peaked, like very high peaked of the PR interval, sir.
PR interval is not peak. Either QRS complex is high. PR interval is the space between P and R wave. Initiation of P
Yes.
wave to initiation of
So
R wave is
saddle-shaped, I read like a saddle-shaped PR interval, sir.
saddle shape PR interval.
Yes.
Unfortunately, I can't give you the key. Otherwise, you draw the saddle shape. You draw the saddle shape in your note and send it to my WhatsApp now. Meanwhile, I'll
Now,
see.
sir?
Yeah, now it's not possible now.
Sir, somewhere I read that one.
No problem. So
I
you
can follow the
go.
note.
So your homework is to find out what is a saddle shaped PR interval. That is what you told me, right?
Yes.
So write down this is homework. After our class, you put one small note that this is the saddle shaped PR interval looks like. This is seen in this condition, and this is the treatment. 3 things for you today. Is that
Okay,
clear?
sir. Yes,
Wonderful.
sir. Sure.
Wonderful. Wonderful. Anyone else? Anyone else? Anyone else? Very interesting.
Here depressions and global ST elevations.
Excellent. So this is the perfect answer Dr. Harry told. It's a
Actually, yeah.
it's a persistent ST elevation. So it's like MI, but in MI there are 2 or 3 leads: ST elevation, ST elevation, ST elevation. In 2 to 3 different lead. While in pericarditis, it's a global condition. Around the heart there is a pericardium. So wherever the inflammation there is a ST elevation. So there is a persistent ST elevation in all lead, isn't it? That is what you want to say, Harry?
Yes, sir.
Yes or no?
Yes, sir.
Wonderful. So this is a persistent elevation of all leads in ECG, right? This is a classical. So anyone else comment on this. So what's the answer basically? We did not reach up to the answer. What's the diagnostic investigation for this patient?
ECG.
ECG. Okay, fine. So what will you find in ECG?
PR depression and ST elevation and all the leads.
Sorry?
PR depression and ST elevation and all the leads.
Where is the depression? Where is the depression?
PR.
PR.
So everyone should know normal ECG is how it looks like, and pericarditis or constructive pericarditis, right? How it looks like. Please post the ECG in the group so everybody will learn and understand. Don't keep the knowledge up to you. The way I am not keeping to me, I try to give everything, whatever I know in a short period of time. And don't keep knowledge with me. I'll share. So you also share. Answer is ECG or EKG. The patient is suffering from acute episode of pericarditis. The changes of symptoms with sitting position, lack of cerebrovascular risk factor, pericardial drum, deviating away from the other diagnosis, right? So this is a classical case, right? So of pericarditis. So you must keep in mind, they may ask not only the acute MI, they ask you pericarditis. Another my subject, my hardcore subject, hematology. You will enjoy this MCQ obviously. Before the start of the ward round, you ask to check a blood results of the patients on a general medicine ward round. A new patient has a following result: prothrombin time normal, partial thromboplastin time increase or prolong, bleeding time normal, platelet normal. What is the most likely diagnosis? Bernard-Scholier syndrome, Glanzmann's thrombasthenia, disseminated intravascular coagulation, hemophilia, liver disease.
E.
Yes, Dr. Ajdani, what's your answer? Tell me, sir, Ajdani, sir.
Actually, answer is hemophilia, sir. Sorry, sir. C. Disseminated intravascular coagulation.
Excellent. Now tell me the point favoring the disseminated intravascular coagulation. So DIC, tell me five
Yes.
things. What happens to hemoglobin? What happens to white blood cell count? What happens to platelet? What happens to PT? What happens to PTT? What happens to bleeding time? And what happens to fibrinogen? Sorry, long things I had given you. It's my hardcore subject, so I'm more interested.
Sir,
Tell
all
me.
values will decrease in DIC, sir. Like PTA, PTT, bleeding time, and platelet, everything will get, except platelet, everything will get increased. I'm confusing.
What's your
Everything will
name?
get. Dr. Preeti, sir.
Dr. Preeti. Is you are joined as iPhone, right?
Yes, sir.
No problem. Okay, Preeti. Tell me.
Platelet will get decreased and bleeding time,
No,
APTT,
1 minute.
and
1 minute. I'm not in hurry. Is it reduced or normal? Platelet count.
reduced, sir.
Reduce. 1 minute. One by one. PT is increased, decrease, or normal?
Increase, sir.
Increase.
Increase.
PTT is increase or PT is increase or increase?
Increase.
Bleeding time is increase or decrease or normal?
Normal.
Increase.
Normal can be normal.
In-
And fibrinogen?
Normal.
Increase in
Normal.
fibrin degeneration project.
Decrease fibrinogen.
As per I
Serum.
know, sir,
1
only
minute.
these two
1
value
minute.
is increased. This
1 minute, sir.
PTT.
Let me clarify you. Don't worry. You will be cleared after 1 minute. Let the Preeti to finish. Platelet count Preeti reduce, right?
Yes, sir.
PT increase, right?
Yes, sir.
PTT increase, right?
Yes, sir.
Bleeding time increase, decrease or normal?
Increase or normal?
Increase or normal. And fibrinogen, serum fibrinogen. I'm not asking about FDP. It is different. Fibrinogen degrading product is FDP. I'm talking about fibrinogen serum. Increase, decrease or normal?
I am not sure, sir. But FDP will increase, I'm sure. But I don't know fibrinogen will increase.
FDG. And what is FDP and what is serum fibrinogen?
Fibrin degeneration product. It is an fibrinogen. It is an enzyme.
Sorry?
It is an enzyme which is causing, which is forming the fibrinogen.
Okay, so FDP is increased and fibrinogen?
Increase?
How come increase?
No,
I'm not sure,
decrease.
sir. I'm not sure.
Sorry?
I'm not sure, sir.
No problem.
I'm not sure. I'm not clear. I'm not sure, sir.
So, Dr. Ajdan. Hello?
Yes, sir.
This is
Yes, sir.
absolutely not, this is 100% not DIC, 100% not DIC, because PT and PTT is increase in DIC, which is normal here. I mean, at least PT is normal here. So, right? Another is platelet is normal here. So it is out of the question, it is DIC, because in DIC, platelet is 100% reduced, which is normal here, and prothrombin time is increased with PTT increase. It is controversial here. Is that clear? Yes or no?
Yes, sir. Yes. You're
Wonderful. Let me come to my chart. 2 minute, you will get 2 minute. Blood clot. Blood clot. This chart is not in any book in the world. So you need to concentrate. That means, right? This is our experience, my 20 years, 25 years, what I understood in hematology. Primary hemostasis, secondary hemostasis. Primary is a platelet, secondary is a clotting factor or factors. This clotting factor all formed in liver. Liver is a generation, synthesis of all clotting factor. This is called primary hemostasis. This is called secondary hemostasis. In platelet, there are two problems. Platelet number problem and platelet functions problem. Platelet number is also what we called as a thrombocytopenia. In our term, we called as a thrombocytopenia, or it is also known as a quantity. Quantitative problem here called as a qualitative problem. Here the quantitative problem, quantity is what is the quantity 1.5 to 4.5, right? Lakhs is a per cubic millimeter is normal, or another word is 150 to 450,000 per cubic millimeter. This is the normal range of platelet. No need to mug up so far. Is that clear to everyone? Tell me yes or no. I will not go further. Yes or no?
Yes, sir.
Wonderful.
yes, sir.
So remember this, don't mug up, right? So quantity problem. So this is quantity, which is measurable, which is quantity. So here quantity problem and one is a quality problem. What happens in a quantity problem when platelets are less than 1.5? It is called as a thrombocytopenia. What are the condition? Septicemia, DIC, infection, dengue, malaria, drug induced, blah blah, long list. Here what happens? Here again lot of condition. HI, heparin-induced thrombocytopenia, thrombotic thrombocytopenic purpura, plus here you can say in ITP, immune thrombocytosis. I had already given you 10 condition in which all the condition where the platelet count gets low, less than 150,000. If it is less than 150,000, it is called as a thrombocytopenia and it is called as a quantitative problem. Quantitative means the amount of the platelet reduced in the blood or serum, and these all are the condition. There is a long more list, but this is commoner one. This is a condition where the functions are normal. So in ITP, say for example, usually functions are normal, only the numbers are low. Here in a qualitative problem, if you see the platelet number 150,000 to 450,000, patient has a 400,000 platelet count, but still patient is bleeding. Why? Because it's a platelet functions disorder. What are the functions of platelet? So platelet function is, this is endothelium, this is vessel, this is endothelium. So platelet, right, first platelet function is the aggregation. So if there is a problem in the aggregation, it is a platelet functions problem. After aggregation, there is a adhesion problem. Adhesion, it does not adhere to the endothelium and make a clot. So it's a Glanzmann's thrombocythemia and Bernard-Shawley syndrome is a platelet functions disorder where the numbers are normal, right? And when there is a functions problem, numbers are normal, right? Numbers are normal, everything is normal. So numbers are normal, right? It is a platelet problem, so nothing to do with the coagulation. So platelet is normal, PT is normal, PTT is normal, fibrinogen is normal, everything is normal. So what is the problem? Problem is that platelet functions. How do you know that this is a platelet functions disorder? So you have a specific test, sets of the test, which you need to run and tell by flow cytometry that this is a platelet adherent problem, this is a platelet, this adhesion problem, platelet aggregation problem. So this is a platelet functions disorder. This is absolutely a different problem. When there is a clotting problem, there is a problem in the clotting factors, which is generated by the liver, right?
Yes, sir.
Right. So let me have one more table with me just to get little more idea to you guys. New slide. I'll create a new slide here. Forget about story of platelet now. Now this is a story of factor. Now you switch the grade, primary to secondary. Secondary hemostasis, first is a primary is platelet. I told you already, story, functions and numbers. Now this factor, here there are two pathway.
Intrinsic.
Two pathway. This is extrinsic pathway outside. This is intrinsic pathway inside. When they both merges, it is called as a common pathway. And this is how the most difficult part comes here, which we mug up whole the life in our medical practice, right? So no need to mug up. 7, 8, 9, 11, 12. So after 7, 8, 9, 11, 12. So where is a 10? So 10 is in the common pathway. 10, I remember by this way, 2 multiplied by 5 is 10. So factor 2, factor 5 and factor 10 is in the common pathway. When this 2, 5, 10 here, it prothrombin convert to thrombin, that is factor 2, and thrombin cause fibrinogen to fibrin clot. And this is factor 13. That's it. This is the most complicated chart. I try my level best to make it simpler. 7 here, 8, 9, 11, 12. Where is 10? So 10 is in common. 2 multiplied by 5. So 2, 5, 10 is in common pathway. When 10 or 10 activates 10A, it causes prothrombin to thrombin. And thrombin, when activates, it causes fibrinogen to fibrin clot. The number of this fibrin clot is 13, or it is also called as a clot stabilizing factor. You go and read it little bit detail. It is called as a clot stabilizing because the 13 number will stabilize the clot, right? And it is a common problem in pediatric or neonate. When you cut the umbilical cord and it has a profuse bleeding, what factor is at the problem? Factor 13. That is called clot stabilizing factor. MCQ in exam, right? So this is the chart, simple. Now next, let's jump to the next thing. How you monitor this all difficult cascade in your clinical practice. So let me more clarify this part. This extrinsic pathway is monitored by prothrombin time, PT, prothrombin. And this whole 8, 9, 11, 12 is monitored by PTT or APTT, activated partial thromboplastin time. This is activated prothrombin time. So PT and APTT, right? So now you don't need to mug up. You don't need to mug up. Whenever, anywhere they say there is a problem in PT, PT is elevated means something wrong in 7. If they say something wrong in 8, 9, 11, 12 means it is APTT is elevated. Why it is elevated? Because it is a deficient or it is not functioning well. That is why PTT is high. If the whole cascade completely very well, then PT, APTT, fibrinogen all will get within normal limit. If everything is in a rhythm, something goes wrong, something crash, something deficient, some mutation develop against any factor, means there is a problem in clotting. Is that clear so far? Yes or no? I will not go further. Yes or no? Yes or no?
Yes.
Wonderful. Wonderful. So factor 8 deficiency, no need to mug up. Hemophilia A. Factor 9 deficiency, no need to mug up. Hemophilia B. Factor 8 deficiency, no need to mug up. Hemophilia C. That's it. Hemophilia A, B, C. Amongst these three, A is more common. 80% of the patients develop hemophilia A because of congenital or acquired, right? This deficiency of or mutation against factor 8, right? So this is called hemophilia ABC. This is factor 7 deficiency. And this completely, if you understand, there are lots of drug. Heparin works at what level, right? Newer oral anticoagulant drug, DOAC or NOAC drug at what level? This one chart will explain everything. This 10A activity, most of the LMWH, low molecular weight heparin, works on 10A. It inhibits the 10A. It will not do the prothrombin to thrombin conversion. It will not cause fibrinogen to fibrin. That is why blood become thick, and that is why you used in a patient with DVT, deep vein thrombosis, or pulmonary embolism. Heparin, low molecular weight, it acts, it inhibits the 10A activity, 10A, factor 10A activity. So this is simple, right? You just need to apply your mind where this drug acts on what level. Nothing comes out of this cascade. So you go and read it once again. So now I had given you the two concepts. One is a platelet concept. Because of platelet, either qualitative or quantitative problem. There is thrombocytopenia and platelet functions disorders. Same way, the secondary hemostasis depends on the what factor involved at what level. You will going to get a defect. Say for example, in general, when there is a problem in the liver, everything gets affected because the liver is forming 7, liver forming 8, 9, 10, 11, everything formed in liver. So when there is a liver problem, some alcoholic patient comes to you. I've seen thousands of alcoholic in my hematology OPD. They present with high PT. Why high PT? Because prothrombin is not generated. Why high PTT? Because 8, 9, 10 not generated. Why? Because everything, this is factory. Liver is a factory for clotting factor. So if liver is that problem, it will not produce the clotting factor and everything gets elevated. So PTT high, PTT also high, fibrinogen is low because fibrinogen is not developed. So what is the picture in liver disease? Increase PT, increase PTT and low fibrinogen because it's not formed. And because of this factor not formed, PT, PTT high. That's it. No need to mug up. No need to mug up. If some patient saying I have only hemophilia A, then patient has a PTT only high. That's it. PT is normal. PT is normal. Why? Because hemophilia 8 is a 8 factor problem, not 7 factor. When 7 is normal, then PT is normal. So PT is normal. Then fibrinogen is also normal because it has nothing to do with the fibrinogen and factor 8. Fibrinogen something related with PTT. That's it. So in hemophilia, PTT increase, PT normal, platelet normal, fibrinogen normal. That's it. So you need to just remember this cascade. That's it. So now let's go back to the questions. Now you try to again answer your questions. Probably this time you will be better. Somebody starting a round. Somebody starting a round. Right? Round. Right? So before you start, I'm doctor, I'm hematologist, I'm starting my round, but my resident says, sir, can you have a look at this gentleman's report, which shows prothrombin time normal, right? Partial thromboplastin time prolonged. So PTT, so remember PTT, where PTT increased. PTT is 8, 9, 11, something wrong at this level. Remember this chart, easy. Bleeding time normal, platelet normal. Now what do you think? What could be the answer? Do you think it is a Bernard-Scholier? In Bernard-Scholier, PTT increase, yes or no? Yes or no?
No.
No.
No, sir.
So Bernard-Scholier is gone. Glanzmann's thrombocythemia, do you think PTT is increased? Do you think PTT
No.
is increased? No. So Glanzmann's gone. Disseminated intravascular coagulation. There are two things, platelet involved as well as factor involved. So platelet involved means platelet low. Is it platelet low here?
No, sir.
PT
No.
and PTT both increased here? No. So DIC is gone. Liver disease. Do you
Okay.
think in liver disease prothrombin and platelets are normal? No. Hemophilia? Yes. That is the answer. Why? Because hemophilia is factor 8. Only PTT is increased. Rest of the thing is normal. Is that clear? Yes or no?
Yes, sir.
Yes.
Any doubt?
No, sir.
This is the chart. Read it later on. I'll share with you. I tried my level best. I don't know how much you mugged up, but I try my level best. Genuinely, thoroughly, I try my level best to make you understand. Is that clear to everyone? Yes or no? So if you mug up, you will 100% forget, because since MBBS, I was, until and unless I became hematologist, even I could not understand what this intrinsic extrinsic, believe me. But then I found out this simplest way. Probably it will help you. What do you think? What do you think?
Great idea, sir. Very easy to remember.
Wonderful. You are a brilliant man.
Thank you very much, sir.
My resident did not teach me this clue. Huh? I asked to my resident, but they are not teaching me this easier. So I found out my own way. Anyway, so that's it. So what my logic and goal is, not just to make you concentrate on the one MCQ of low platelet or PTT. Now you can answer thousands of PTA, PTT. You just remember two things: primary, secondary. What is that problem? Platelet problem, factor problem. Right? Platelet problem, forget about factor. Factor problem, forget about platelet. Just concentrate what is abnormal. Forget about normal. If you concentrate PTT high, 8, 9, 11, 12. That's it. Got it? If you have this problem, Glenn's platelet functions disorder, platelet should be normal, right? So remember this chart. If you remember this chart, then you will be more happy. Last but not the least, couple of questions, then we'll catch up. 31-year-old woman present to ED, that is emergency department, sudden onset of left-sided chest pain and difficult breathing. She states her only medication is a birth control pills. She has smoked 1 cigarette pack per day for last 10 years. She is tachypneic, 24 breath per minute, and her heart rate is 120 beats per minute. Physical examination reveals diminished breath sounds on the left and the trachea deviated on the right. What's the most likely diagnosis? Pericardial tamponade, pulmonary embolism, tension pneumothorax, and
C.
hemothorax.
Tension pneumothorax.
Yeah, let's see. Let's see what other experts. I think this is a lollipop questions for you guys. Yes, it is a tension pneumothorax because it's a very clear cut, right? There is a one-sided chest pain, number one, difficulty in breathing, right? The biggest clue is on physical examination is diminished breath sound. So where is the diminished breath sound happen? When there is a fluid or air filled in the lung, isn't it? If fluid filled, the breath sounds reduced. If the air filled, breath sounds reduced. So either fluid or air filled up, and the trachea is deviated to the opposite side, right side. Trachea, because pain is on left side, trachea is on right side. So there is a shift of the mediastinum. So something filled up in the chest, and that is a tension pneumothorax. Right? In pericardial tamponade, what happens? The heart sounds are muffled. The mediastinum did not shift to the opposite side. Right? Pulmonary embolism, there is a no shift of mediastinum. There is no shift of this right or left side. Right? It is a clot in the blood pulmonary vessels. That's it. Right? And just to confuse you, they had given you the birth control pills, right? Patient is on birth control pills. So you think that something clot in the, but in pulmonary embolism, there is a never ever shift of mediastinum or trachea to the opposite side. And hemothorax, there is a just reduce the sounds, right? Hemothorax. So this is classical case of tension pneumothorax. And last but not the least, it's a full of science. Last questions for today. A 1 month old child fed after which he has vomitus that is forceful and winds up across the nursery. The vomitus is non-bilious and non-bloody. Physical examination reveals a palpable mass in the abdomen. Upper GI series is ordered. Which of the following is most likely finding on his radiological examination? My triad again comes in the picture. Diagnosis, investigation, treatment. So if you don't know the diagnosis, difficult to answer.
Diagnosis is the pyloric stenosis.
Okay, how we know?
This
Non-bilious
palpable mass,
projectile vomiting.
non-bilious vomiting, and child, small child.
Small child, non-bilious vomiting. Okay, fine, fair enough. Let's see. Yes, Catherine, you were speaking something.
No, sir, I agree with him. The diagnosis is pyloric stenosis. There is projectile non-bilious vomiting, sir.
Fair enough. What could be the sign? String, donut, bird beak,
string sign.
String sign, string.
Okay. So string sign, let me write down here. String sign is seen in hypertrophic pyloric stenosis. Is that clear? Ajdan.
Yes, sir.
Okay. Yes. Toprak, what is a donut sign and where it is seen?
Is donut sign is intussusception.
Intussusception. Excellent. Intussusception is a donut sign. What is a bird beak sign and seen in what condition?
It is echolalia.
Echolalia cardia.
Excellent. Echolalia cardia. What is a steeple sign?
It's croup.
It's croup. Wonderful. You all are very brilliant. Huh? You don't need my lecture now. Murphy sign.
Cholecystitis. I mean cholelithiasis.
Cholelithiasis. Okay. Is it a radiological sign or clinical sign?
Clinical sign, sir.
Clinical sign. Excellent, brilliant, brilliant. So this all four are the radiological sign where you can see on X-ray or film, and this is a clinical sign which you evaluate. I collected all the pictures. This is called as a, right here you can see the classical hypertrophy pylorus. This is pylorus, esophagus, lower end of esophagus, pylorus, and then stomach, fundus of the stomach. So hypertrophy pyloric stenosis. So here there is a stenosis, and because of that there is a string. It's like a string. You know the guitar string, ting ting ting, guitar string. So it's a
Yes,
string
sir.
sign. It's a very thin, these things, right? So it's a string sign. This is a bird beak sign. So this is a bird and this is a beak. This is a bird. I have shown you the right. So this is a bird beak. This is a bird beak. See, this is a bird beak. Is that clear? So this
Yes,
is
sir.
a bird beak. This is a eclasia cardia. This is a donut. So you know this is this and this and this is donut. It is intussusception. This is a donut sign. This is what the steeple sign. Steeple is like a sharp triangle. Steeple, scroop, or it is also called as a laryngotracheobronchitis, if I'm not wrong. In croup is laryngotracheobronchitis, right? It is a
Correct.
croup sign.
Yes, sir.
And this is a thumb up, the thumb up sign, right?
Glottitis.
This is epiglottitis. So these are the various signs of radiology. So I think that's all I'm done for today. I think hopefully you enjoy my thorough lecture, and I try my level best unbitterly speak for more than 90 minutes. So it's time for quick feedback. Something new you learned. I don't want to listen something, I mean, monotonous, but something which you feel that, sir, this is something new for me, that I would be happy.
Lots of things learned today, sir.
Wonderful. Wonderful. Especially what like the most to you?
Your field, right, sir? This blood chart. We read
Okay.
about the. It's a very informative and very easier way to remember for a lifelong. I'm
Wonderful.
impressed of this chart, sir. Thank you very much for giving this kind of easier way to learn, sir.
Wonderful. Yes, anyone else? Anyone else? Yes, Neelam.
Sir, we almost covered all the systems. I
Which?
think
What? Sorry, what you are saying?
we covered almost all the systems, sir.
Very nice. Yeah, because
So
Dr.
that was the
Neelam,
best part about it.
yeah, because I try to do in mock test. I'm not presenting you blankly that I'm Saturday evening, I'm sitting and preparing. I start my homework today for the next Sunday. Believe me, then I can make this lecture more effective. You understand?
Yes, sir.
Until and unless I explain you, it looks boring to you. But it doesn't look boring. Why? Because we are touching lots of topics nearby, and we
Yes.
try to stretch our neurons as well. Otherwise, what we never thought about what is gram positive, gram bad. We mug up, mug up, mug up. We don't know what is
Right, sir.
MRSA, MRSA. And let me tell you, I'm not trying to scare you guys, but nowadays they are getting little more tougher. Believe me, in the exam. Right? They won't ask you simple line, oh, what is the treatment of choice for MRSA? That's it. They won't ask you. They ask you little tricky things. So I want you, everyone, to think of it. Everyone to go bit in detail, read more in bit detail, right? So whatever they ask, we can easily crack the exam. That is why I'm giving, why I'm going platelet chart and factor chart. I just read a fast in 1 minute, 1 hour. I will finish 20 questions, not 20 questions, but nothing you will grasp, nothing you will remember, nothing you will understand the things. If you understand now this, I guarantee you, you never go wrong. In the exam, you confidently give the answer, 100%. So our main goal is to concentrate on the quality reading, not the quantity reading. I don't want anyone to read 8 hours, 10 hours, 12 hours a day. Read just 4 hours. But this 4 hours could be a quality of 8 hours, 10 hours, 12 hours. Read what exactly what you are reading, what going in your head, what going inside your brain. That is more important. And try to read, try to do more mock tests. This is my personal advice to each and everyone. More the mock test you do on website, more the excellence you will achieve, believe me, because this is the only way by which you get to know. Na? You tell me your score, you drop me your score, right? With the grace of, I mean, just keep a God in mind and give me the score. Na? If you are not getting 7 out of 10 correct, it's not good score, believe me. I don't want to disappoint you, anyone. But this exam, and this is like a middle level questions I selected. I did not select very toxic questions. I can, otherwise you get hardly 1 or 2 correct out of 10, 15, believe me. But in exam, they won't ask you 100% of 100% easy. They ask you in between that 70, 80, okay, okay. Only 20, 30% is toxic. But what happens? We are not clear with the middle level question, then how we gonna go for like very advanced, very toxic questions? So you need to prepare well. 4 subjects, again and again, I am telling you: surgery, medicine, gynec, pediatric, and legal ethics and emergency. These are the few core subjects which you concentrate very well, and you must have to prepare well. The way we are discussing every Sunday. Otherwise, why should I am every Sunday? Last 4 months, I'm breaking my head doing nothing, and I'm, instead of enjoying my Sunday, I'm generously, sincerely discussing the question with you guys just to make you learn more. That's why I'm here, right? Otherwise, everyday classes are going on. No? Why I should also need a break once a week, but I'm not taking. The way I have my commitment towards you, I reciprocate the same commitment from your side to me. And this is not for me. If you are passed, you will be happy. Obviously, you will be happy. I will be also happy, but you are the first one who will be the happy. So try to concentrate, try to do more sincere work. Don't waste a lot of your time in chit chat and WhatsApp and blah, blah, blah. It is, you do 24/7 once you crack the exam. Enjoy, but be sincere for next more 1 month and try to crack the exam. Best of luck. Thank you very much. I will update my this
Excuse
lecture
me, sir.
by evening. Yes.
Sir, I have one question.
Yes.
In this online, whenever we are going to study, we have only subjective mock test, subject wise.
Yes.
So, sir, why not you are putting in the like all subject together mock test so that we can like we can detect our quality, that how much
Yeah.
we are getting in combined subject.
Coming to that answer, PROMETRIC 1000, practice MCQ, and recalls. These 3 chapters are on the website. This all mixture of what we are discussing now. So it is not at all subject wise. It's mixture of all questions. So you do, if you want to do mixture, select any PROMETRIC 1000 MCQ mock test, select practice papers, or select recalls. That's it.
I already went through these 3 parts, sir, as you said.
Yeah.
So that will be enough for the exam, that much question, that 3
If
part.
you believe me, brother, 90% of the people crack this exam with this only last 10 years of experience I'm sharing with you. I'm not trying to make you feel good, but hardly 10% people fails who did not prepare well. Otherwise, I can introduce you to thousands of doctors who crack with this, and we are doing
So,
sincere efforts to make this
so,
material.
so
So you,
basically, you are saying, sir, if I will go through these 3 part, like as you said, that
you are
1000
done.
MCQ
You are
recall.
passed.
So if I will go through that 3 part multiple time, maybe 4,
No,
5,
even
6.
go thoroughly, sincerely with one time, even you pass. See,
Thank you very.
end of the day, you need to understand the concept, right? Whenever you
Yes,
give
sir.
me any MCQ of hematology, I can very easily crack. Why? Because I have concept in my mind. If something
Yes, correct.
anemia, pancytopenia, leukemia, lymphoma, myeloma, aplastic, MDS, sickle, you name the disease, I treated thousands and thousands of patients. So I have fixed protocol in my mind. If something comes this is how we have to approach. That's it. I never mug up the book. I never, I mean, open up the book and treat my patients in a everyday's OPD. You understand? So you need
Yes,
to
sir.
cultivate the concept. Why this not? This 5 signs, right? Sting sign, donut sign, bird sign, steeple sign, Murphy. So if you mug up, you will 100% forget. But you need to understand, okay, string, how the string looks like. Okay, bird beak. So how the beak look like? So where is the narrowing? Narrowing is in the achalasia. What is the mug up? What the mug up? Nothing. Steeple. Steeple is like upward triangle. Where it's in? It's in trachea. It's a croup. No need to mug up. That's it. But what we are doing? Mug up, mug up, mug up, mug up. We will forget. Don't mug up. What they are trying to explain, and the same thing can be visualized on your picture or not. If you remember, register in your mind, you can answer it easily. That's it.
Thank you, sir.
Thank you very much.
Sir, I have one question. If
Yes,
you,
please. Yes, sir.
I'm just starting out with your preparatory course.
Yes, sir.
What I wanted to know is like how much time should I be thinking of before?
If you are a practicing doctor, try to take 2 to 3 months of time. If you are full timer in this preparation, try to take 4 to 6 weeks.
Okay, sir.
Because
And could you also post a syllabus so that I can have a checklist of what needs to be
it's
covered?
all on the website, sir. Still, I'll share with you. Drop me your message on my WhatsApp. Everything is on our website. What subject, priority wise, everything is there. But still, I'll try to help you out and I'll post it for you.
Okay, sir.
Sir,
Thank you.
Yes.
So what do you mean by full timer? Like as you said, if
Full
I am
timer means somebody is not doing any job, just preparing.
so
that is full timer.
so that is 24 hour, no sir. So how long?
Yeah, I mean 24 hours means, I mean, who is just preparing for exam, that is full timer by my sense. And if you are doing job and preparing alongside the job, 8-10 hours of job, right? Then it's difficult, little difficult to concentrate 3-4 hours. It's not easy, right? To spend after 8-9 hours of duty, clinical practice, either job, hospital, or your own practice, it's difficult, little difficult. So you spend little more time. The bottom line is that I don't want anyone to get fail, right? That is my goal. No one should get fail. No one, right? So you prepare
Yes,
well.
sir.
Na? If you are taking 1 or 2 week extra, I would be happy. See, if you are doing a job and practicing instead of 3 months, you give at 3.5 months, I would be fine. But I would not be fine if you get fail. And if you drop me result that, oh, doctor, I did not crack the exam, that at that day, I feel that my day get wasted, believe me. Because
Okay,
you
sir.
fail means ultimately I fail, being a mentor.
Hopefully it is not going to happen, sir.
100%
I don't
not
want.
happen.
Yes.
100%.
Thank you, sir.
Okay, best of luck. Once again, last but not the least, please post one Google review on our a group of free mock test. So we would be happy. Please post one review.
Sure, sir.
Thank you very much. Take care. Good day.
Thank you,
Enjoy your
Good day.
Sunday. Keep in touch and also prepare well the homework. Okay, Tobrak. Best of luck.
Okay.
Thank you.
Bye bye. Take care.
Bye.